So I will be talking about heavily calcified coronary lesions. I will give you some small overview about the methods we have, and I will tell you why atherectomy is not the only solution we have. So as a specialist for complex high-risk indicated patients, I would like to show you some characteristic factors which allow us to classify the given as a cheap procedure. And these factors comprise of comorbid conditions like heart failure, diabetes, advanced aged, peripheral vascular disease, unstable angina or STEMI, or prior surgery. The other thing which is very important is concomitant cardiac disease like valvular disease. And of course, the coronary anatomy is extremely important here. And from anatomical point of view, we should highlight the multivessel disease, chronic total occlusions, left main disease, and of course, calcified lesions. Sorry, I have to stay. I would need to switch the video off, otherwise my internet connection is breaking down all the time.
No, Dr. Krzysztof, you go ahead.
Because the moderator keeps writing me all the time to start my video, and I won't do that because I want my videos to run smoothly and not my internet connection not to crash again.
Sure.
Okay, so overall, speaking about cheap interventions, we have to say that population undergoing this intervention is growing, and scientific data regarding this intervention is quite controversial and seems favoring CABG at least in eligible patients. The market penetration of technical tools needed to address these patients is poor in most countries, and even in countries with well-developed health systems, results are very operator dependent. So the knowledge of the operators how to use all this equipment is sometimes could be sometimes better. And CHIP patients are quite underserved, even thought they have the highest ischemia burden and would gain the biggest benefit of contemporary revascularization strategies. And what makes calcified lesions so difficult to treat, and why is it important to treat them properly? There are many data on that, and one of this old Horizons MI acuity trial showing us that the death rate, cardiac death rate, myocardial infarction rate, and TLR and MACE rate are always higher in patients with severe calcifications compared to patients without coronary calcifications. And why is it that this is the question which came up after the first presentation? Why is it so important to treat calcified lesions properly? It's quite simple. If we don't treat the calcified lesions properly, we will be having a hard time with delivering our gear like balloons and stents to the lesion. And even if we deliver them, we can possibly have a problem to achieve complete expansion of the stent and complete apposition of the stents. And aggressive dilatations with conventional balloons can also contribute to higher perforation rate or edge dissections. And which devices do we have to address these lesions properly? So first, non-compliant balloons, then ultra-high pressure balloons like NC balloon, cutting and scoring balloons called also as modified balloons techniques, atherectomy device like rotational atherectomy, like Rotapro, and orbital atherectomy, like CSI Diamondback system. And of course, we also have litotripsy, so shockwave, IVL, and we have also laser, which I personally don't have any experience with. So talking about balloons, so I prepared, or I found this table showing us the available balloon techniques. So non-compliant balloons, we can go up to 80 atmosphere. Of course, in reality, we could go much higher than that. OPN, super high pressure balloons, are twin layers balloons, which allow us to give extra support to sustain high pressures. And I sometimes go up to 50 atmospheres without any big problems with that. So they are sometimes very helpful. Cutting balloons, which do a radial incision in calcific tissues with the atron blades, and scoring balloons, which are here, the conventional scoring balloons, which are semi-compliant balloons with focal force concentrations, and they prevent balloon slippage, and of course litotripsy balloon, which is completely other technique we won't be talking about today. So can one say that one specific method is better than the other in terms of success rate? Yes, I do think so. There are some scientific data showing, like for instance, this PREPARE-CALC trial, which is a few years old, but it's still showing us that the strategy with modified balloon was inferior to rotational atherectomy regarding strategy success. 16% of this population which failed the strategy with modified balloon because of the fact that the lesions were not crossable by any balloon, or were not adequately dilatable, had to be treated with rotational atherectomy. It is very often, very frequently cited study to show the superiority of rotational atherectomy over the modified balloon strategy. But let me put it in the other way. The data show also that you can treat over more than 80% of your patients with modified balloons, and the success rate can be even higher than this 80% with the use of modern scoring balloons like this Wedge, right? So the chance to treat a very heavily calcified lesion with the standard modified balloon is not bad, as I told you, but with the newest device like this one, can be even higher. Thanks to higher rated burst pressure, we are able to apply higher force to the target lesion, which may facilitate even better and even better results and bigger calcium fractures. And moreover, a modern scoring balloon like Wedge has the lowest compliance with higher pressures, reducing potential dog boning effect, and thus having lower risk of vessel perforation. And not to talk about theory only, I would like to show you two cases to highlight that in order to be able to treat every patient, we need complete portfolio and complete toolbox with both all balloons and atherectomy devices. And here we have a 75-year-old patient with type 2 diabetes, stable angina, and the angiography revealed large eccentric plaque in the left main blocking axis to the LAD. So we took the patient, we started with wiring the LAD with Whisper light support wire and with standard microcatheter, which was not possible. Then we upgraded to enhancer double lumen microcatheter and Whisper light support, and then even to SUO3 wire, but it was unsuccessful. So you can see on the right panel that the wire is going up, but it's not going forward. So it was quite difficult to wire this LAD around this this plaque. So we wired the circumflex with Viper wire, so it's diamondback atherectomy, orbital atherectomy, and then we performed the atherectomy with low and high speed to modify and reduce the plaque burden protruding into the LAD ostium. So this is the atherectomy, and then we re-attempted to wire the LAD with the SUO3 wire, which has extremely low tip load, so 0.3 gram, and with the double dome microcatheter, but we were still unsuccessful. And then, as a matter of last chance or last resort, we inflated a blocker balloon on the circumflex guide wire to redirect the other wire into the LAD, but we still were unsuccessful, unfortunately. So 2 days later, we had a other plan. So we bought a Teleflex microcatheter with 120 grade angled tip, and we managed to wire this vessel quite easily within 2 minutes, and then we did some pre-dilatation with some small semi-compliant balloons, and we wired the LAD with Viper wire and performed one orbital atherectomy once again. And then we stented it, stented left main towards left LAD, and then left main towards circumflex artery as indicated in culotte technique. Then, yeah, we took care about this this other bifurcation here to diagonal branch, and at the end of the day, the result was okay, and the IVUS imaging was also good. So we were happy with the results, but it was quite a difficult case, showing us that you still need some, still need some atherectomy device for addressing this kind of lesions. In the second case I would like to show you, it's a nice case with Wedge NC scoring balloon. It was, I think 1 week ago. It was a 57-year-old male with chronic kidney disease, hypertension, and unstable angina. And the angiography revealed a long lesion of the dominant right coronary artery. We wired it, and we performed HD IVUS imaging of the vessel, and we could see some calcifications in the mid part. There was an angle, arch angle of 270 grade, and we had some, quite healthy, portion of the vessel proximally. So what we did was wire it and put the Wedge NC into the vessel. You can see it could be beautifully advanced into the vessel without any problems over this floppy wire. Here on the right panel, you can see the scoring element, this metal part. Couldn't see it very good. So it opened the lesion. The immediate result after the pre-dilatation was okay. You can see some controlled dissection of the vessel, and so we performed the IVUS imaging one more time, and we could see some fractures, and here some dissection proximally. And after standing it with a 4.5 millimeter stand and post-dilating it with 5 millimeter NC balloon, the end result was good. And this 50% stenosis, we left it alone because on IVUS it was not relevant. So the final result was quite favorable. So to sum it up, we have many algorithms how to treat calcified vessels, and they are based on assessment intravascular imaging, which will show us more calcification than angiography does. And depending on what kind of morphology of the plaque we will find, we can choose which modality of plaque modification we should go for. And if there is no possibility to cross the lesion with balloon or imaging catheter, we should directly go to atherectomy. But as I highlighted before, a modern scoring balloon is a really very good option to achieve good, very high success rate in most of the cases. And summary and take-home messages. I would like to highlight that similarly to CTOs, calcified PCIs can stretch capacity limits of both interventional devices and interventionalists, and most calcified lesions can be treated efficiently with the help of modern scoring balloons. However, in some cases, an upgrade to atherectomy techniques is needed. And complete toolbox is crucial to achieve consistently good results with low complication risk and acceptable procedural time. And yeah, what we also know, or what we should know, treating this patient, which should be prepared for changing conditions, know how to treat possible complications and try to avoid them, of course, and don't rely on miracles, know devices and techniques to use. And this could allow us potentially to make complex cases as easy and possible. And I think most of the patients can nowadays be treated very well with PCI if we know our toolboxes and if we know how to use them. So this is the difference which our patients are so thankful for. Thank you so much for your attention.